Walaikum Assalam, sir.
Walaikum Assalam, sir.
तो आप लोगों ने ट्रॉमा टू द परमानेंट डेंटिशन तो आई होप पढ़ लिया है. Am I right?
Yes, sir.
Okay. So whenever there is a dental trauma and we talk about the operative session, the trauma can affect either the enamel dentine or the pulp. Either it can affect the supporting structure like the periodontium, the pedial ligaments, or either it can even destroy the bone, because in trauma the bone can also fracture. So we'll discuss the trauma series in 3 different parts. In the first part, we'll be discussing like the uncomplicated fractures in which only enamel is fractured, and then the uncomplicated fracture where only enamel and dentine is fractured, and then the complicated fractures in which enamel, dentine, root and pulp is involved also. These are the complicated fractures, and these fractures involve the enamel, dentine, pulp and the root. Anything that involves, I told you that the trauma can affect the tooth by fracturing the adjust enamel, dentine and the pulp. This is type 1. Then it can affect the supporting structures like in concussion, subluxation and lateral luxation. These injuries affect the supporting structures. And then there can be the alveolar fracture in which the bone is fractured, and then the complete loss of the tooth from the socket. That is avulsion. So beginning with the first, the enamel fracture. If the enamel is fractured and the small enamel is fractured, then we are just try to smooth that roughened enamel margin. And if the patient has an aesthetic concern, we can restore it with the composites. If patient has not an aesthetic concern, we are just supposed to smooth that small enamel fracture to smoothen it, the rougher margins. Then there is enamel and dentine fractures, large enamel fractures. If there is a large enamel fracture, that can be restored by using composites. Again, aesthetics is the only concern in enamel fractures, because enamel is not been communicating with the underlying tooth. It's the highly mineralized part. So in interiors, the aesthetic is the only concern. So we are supposed to build it with the composites. These is a small enamel fracture showing us that there is small enamel breakdown, and the such areas are anesthetic, because the first window, whenever you present and meet with someone, the first pleasant impression is your smile. You present him with your smile, and in smile, if you have such rougher teeth in the anterior part, that usually create a bad image. So we are supposed to fill them with the composites to look like the natural teeth. So then there is enamel dentine fractures. In these fractures, the enamel and dentine both are fractured, both got fractured, and the pulp is not exposed. So when the pulp is not exposed, but the dentine is fractured, we are supposed to seal that tubules. हमने dentine को seal करना है, because it will carry the sensations. So we're supposed to, if it's small, we are supposed to seal it with GIC to prevent the micro leakage. In case of large tooth structure loss, restore it with composites, again for the aesthetic concerns. We have to seal it to prevent the micro leakage, and then if it's large, then we have to restore with composites, again for the aesthetic concerns. Got it?
Yes, sir.
Okay. Then the next, this is the large fracture, showing us the enamel and dentine involvement. So such teeth are supposed to be sealed specifically, because the dentine has an amazing nature that it has a dentinal fluid that usually flow outwards at 14 millimeter of mercury. So we are supposed to seal that tubules. अगर हम उन tubules को seal नहीं करेंगे, then there will be ingress of bacteria and that can be harmful for the pulp. So we are supposed to restore this with the composites. Again, aesthetically it's pleasing, it's aesthetically bad. So then coming towards the enamel dentin and pulp exposure, ऐसे fractures जिनके अंदर pulp भी साथ expose हो जाएगी, उनको हम enamel dentin pulp fractures कहते हैं. These are the complicated fractures. Again, अगर possible हो, हम now we are talking about the primary dentition, not the permanent dentition. What is partial pulpotomy? Anyone have an idea? If the trauma is fresh, we are supposed to remove just the coronal pulp that is in the chamber. इसको हम civic pulpotomy भी कहते हैं, CVEK, civic pulpotomy. इसके अंदर से हम chamber में से सारी pulp को remove कर देते हैं and the radicular pulp stays vital. This is known as partial pulpotomy. हमें partial pulpotomy try करनी चाहिए because immediately after trauma, we have 48 hours to prevent the pulp space infection. अगर हम इन 48 hours के अंदर partial pulpotomy कर देंगे तो the radicular pulp stays vital and the apical part will keep growing, like उसकी apexogenesis continue रहेगी. But still अगर partial pulpotomy से result achieve नहीं होता, then we have to go with complete pulpotomy. हमें पूरी pulpotomy करनी पड़ जाएगी. अगर इससे भी नहीं होता, then we have to go with the pulpectomy. Means we have to remove the radicular pulp as well. And extraction is an alternate option. Again, this is the fracture that is involving enamel dentin and the pulp. More than half of the tooth is gone. So we are supposed to start from the least invasive towards the most invasive options like partial pulpotomy, complete pulpotomy, pulpectomy, and extraction. You can see that here the pulp is involved. Here the pulp is involved. Got it?
Yes, sir.
Sure. Okay. Then there are fractures जिनके अंदर crown root fracture हो जाती है without the pulpal exposure. These are also the complicated fractures. Means these are the diagonal fractures that involving the enamel dentin and the root surface like the cementum. Ideally, in primary dentition, such tooth should be extracted. But if there is no pulpal exposure, ऐसे दांतों को रेस्टोर करना डिफिकल्ट होता है बिकॉज सच फ्रैक्चर्स आर सब जिंजाइवल. तो इसके अंदर हम अगर फ्रेगमेंट रिमूव करके रेस्टोरेशन की तरफ जाएंगे, दैट वुड बी अ डिफिकल्ट ऑप्शन अगेन, बट वी हैव टू मेंशन इट कि वी विल रिमूव द fragment that is fractured and then we have to restore it, and eventually the extraction is the option. According to IADT, International Association of Dental Traumatology guidelines, anything that hampers the permanent tooth from its growth, we are supposed to extract the primary teeth. Primary teeth के अंदर mostly trauma के अंदर हम extraction ही करते हैं, according to International Association of Dental Traumatology. Again, you can see a diagonal fracture here that is affecting the root structure as well. तो इस portion को restore करना इतना easy नहीं होगा. If we remove the fractured part, तो we are unable to restore in such a depth. इस depth के ऊपर इसको हम restore नहीं कर सकेंगे, specifically when we are in kids, as the enamel dentin fractures extending below the gingival margin. If there is any query, you can ask me. Otherwise, I'll move on. अभी तक हमने कौन कौन से फ्रैक्चर्स पढ़नी है? Anyone?
Enamel, enamel dentin, enamel dentin cementum, or
Okay.
root fracture.
Okay. Then there is crown root fracture with pulpal involvement. पहले हमने पढ़ा crown root fracture with no pulpal involvement, no the crown root fracture with pulpal involvement. इनके अंदर definitely the fracture involves the enamel dentin and the root surface with pulpal involvement. So partial pulpotomy, complete pulpotomy, pulpectomy followed by the restoration or extraction. Ideally, such root fractures are not well managed by the fragment removal and the restoration because they are subgingival, and ideally the space can be left and they cannot be filled ideally. So we are supposed to usually extract them ideally, and the treatment depends upon the child maturity. Matlab how well he is in the chair to allow us to help him. Like this fracture, you can see there is also the pulpal involvement, so we cannot restore the teeth in such a depth. इतनी depth में उसको हम restore नहीं कर पाते. So, but again, you have to mention all the options like partial pulpotomy, complete pulpotomy, pulpectomy, and then the extraction. But ideally, they should be extracted. Then there is the root fracture, and the root fracture ideally should be divided into the coronal 1/3, the middle 1/3, and the apical 1/3. But here we are generally talking about the root fractures. If there is a root fracture, like it's shown in this picture, we are supposed to extract the coronal segment, and the apical segment should stay vital because the apical plexus of fracture are still in connection, and we are supposed to preserve that connection by removing the coronal segment and retaining the vitality of the apical segment. Usually, the coronal 1/3 fractures have the poor prognosis because there is a lot of movement in the crown, and again on the movement हम उसको splint नहीं कर सकते, and with splinting वैसे बच्चों में the first I'm telling you कि बच्चों में हम splinting वगैरह नहीं करते. Ideally that can lead to the ankylosis, and when ankylosis will happen, the permanent successor जो ऊपर से आ रहा है, that will not guide its part through this one. Usually extraction of the tooth is the option. If the coronal segment is mobile, it can be removed and the root fragment is left to resorb automatically. Follow up by the clinical and the radiographic examination at 6th, 8th week and 1 year until the eruption of the permanent teeth. And what we are checking on the follow up, हम follow up पे क्या देखना चाह रहे हैं? Speak up. क्या देखना चाह रहे हैं शाबाश?
सर अगर हम एपिकल पार्ट को वैसे रख रहे हैं तो वो खुद ही एक्सफोलिएट होगा बाद में या हमें निकलवाना पड़ेगा, निकालना पड़ेगा?
The permanent tooth is guiding it. मतलब the primary root of the tooth is just to guide the permanent tooth. वो एक सिस्टम है नेचर का कि जो परमानेंट की क्राउन है वो डिसिडुअस की रूट्स को डिफ्लेक्ट करता हुआ ओरल कैविटी में आता है. तो हमने यही देखना है, हम इसीलिए उसको क्लिनिकल और रेडियोग्राफिक एग्जामिनेशन पे रख रहे हैं कि जो एपिकल पार्ट हमने सिटू में छोड़ा हुआ है, is that is developing some periapical lesion or not. If it's not developing, so is it resorbing or not according to the NOLA stages of tooth formation? I guess you all have studied the NOLA stages of root formation, that where the crown start forming 1/3 form, 2/3 form, almost form, and again vice versa for the root. याद है सबको NOLA stages of tooth formation?
जी सर, पढ़ा हुआ है.
Good. So हमने follow up में सिर्फ यही देखना है कि जो apical part हमने छोड़ा हुआ है in the bone, if that is developing some lesion or not. Ideally this stays vital because इतना depth में infection अगर हम coronal part को जल्दी निकाल देते हैं, so usually they stays vital and they start resorbing when the permanent tooth is coming. अगर नहीं तो फिर then we have to extract it.
Got it, sir.
And then concussion. The first fractures we talked about that were the involving enamel dentin cementum of the pulp. Now we were going toward the supporting structures. इन्हीं ऐसे fractures जो कि tooth के गिर्द उसके periodontium को भी involve करते हैं, उनको हम concussion, subluxation, luxation, and lateral luxation की form में discuss करेंगे. The first one is a concussion. The concussion is like a blow. When someone blow the tooth, where the tooth don't displaced, but there is slight mobility, like the loosening of the tooth happens. In concussion, there will be no displacement, but the tooth is slightly loosened in its socket. And the TTP is positive. The tooth is standard to percussion. Radiographic abnormalities nazar nahi aayenge. Ideally, we are supposed to splint it if the tooth is permanent, but in deciduous, again, I'm repeating, we don't splint the tooth. अगर हम उसको splint कर देंगे, that will lead to the ankylosis. So no treatment unless fistula develops. And अगर fistula develop हो जाएगा, then we are supposed to extract the tooth. In concussion, we are supposed to keep the patient on the soft diet. हम उसको soft diet पे रखेंगे, mouth washes का use बताएंगे, and we will some analgesics to remove the to cope up with the pain. And if the mobility did not get less, then we have to extract the tooth. Got it? समझ आ गई कंकशन की?
Yes, sir.
कंकशन में सिर्फ ये याद रखना है कि देयर विल बी लूजनिंग ऑफ द टूथ बट नॉट डिस्प्लेसमेंट, मतलब दांत अपनी जगह से डिस्प्लेस नहीं हुआ होगा, एंड देयर विल बी टेंडर टू परकशन, एंड यूजुअली वी डोंट ट्रीट until and unless there are some symptoms like fistula, and in primary dentition if fistula develops then we have to extract the tooth. Follow up like 1 week, 6 to 8 week, these are general follow ups जो अपने ideally हर trauma case के अंदर लिखने हैं, like first week, 6th week, 8th week and then 6 months and then 1 year follow up. ये IADD की गाइडलाइंस के अंदर हर किस्म के ट्रॉमा को हमने फॉलो अप पे रखना है. Then there is subluxation. In subluxation there will be increased mobility, मतलब mobility थोड़ी और बढ़ जाएगी, but the tooth is still not displaced, अभी भी वो displaced नहीं हुआ. Even the mobility is like grade 2 mobility, it's fall in subluxation, but the tooth is yet not displayed. And the bleeding from the gingival crevice may be noted because of the mobility of the tooth. The bleeding from the sporting structures will be evident. Again, no radiographic abnormalities will be seen on the first checkup, and no treatment is needed until and unless some abnormality will develop. And अगर कोई abnormality नजर आती है, then what we have to do? क्या करना चाहिए हमें फिर? रूट कनाल कर देनी चाहिए? असद?
जी सर.
रूट कनाल कर देनी चाहिए?
सर ट्रॉमा के केस में तो नहीं.
नहीं, आई एम बी प्रिसाइज. देखें हम प्राइमरी टीथ की बात कर रहे हैं, तो प्राइमरी टीथ के अंदर यूजुअली हम
सर नहीं एक्सट्रैक्ट कर देते हैं.
एक्सट्रैक्ट कर देते हैं. शाबाश. यानी हम वो जरा सा भी मसला करेगा तो वी हैव टू एक्सट्रैक्ट इट because we are looking for the permanent successor that is coming in its place. Then coming towards, and again look, brushing with soft brush, use of chlorhexidine with cotton swabs twice a day for a week, and keep the patient on soft diet. ये दो बातें आपने बड़ी याद रखनी है, ये अपने हर किस्म के ट्रॉमा के अंदर मेंशन करनी है. ब्रशिंग with the soft brush and use chlorhexidine, and keep patient on the soft diet, and then keep the patient on follow up like first week 6 to 8 weeks. ये दो बातें you have to add in almost all kind of traumatology. जितने भी आप permanent में पढ़ेंगे, primary में पढ़ेंगे, ये चीजें में mention करनी है. Then coming towards the extrusive luxation. What do you mean by extrusive? Extrude हो गया दांत. The tooth is extruded from its socket. मतलब the tooth is falling down from the socket. It can be moved in any direction like labial, lingual, palatal, but not back in the socket. Palatal, apical नहीं जा सकेगा. Rest, every movement is possible, but no apical movement is possible. This is extrusive luxation. This is partial displacement of the tooth from its socket. यानी दांत अपनी socket से displace हो चुका हुआ है, and tooth appear elongated and mobile. It's mobile because the pedial ligament has been ruptured. The pedial ligament जो कि इसको पकड़ के attach किए बैठे थे with the bone, and वो अब rupture हो चुके हैं. Radiographic increase the periodontal ligament space. Pedial space बढ़ चुकी है because the pedials are ruptured, so the space is more. Like in this picture, like you can see here, there is more space. The pedial space is more. The tooth is extruded from the socket. Okay. तो क्या करेंगे इस तरह के केसेस में? क्या करेंगे जी?
So primary teeth है तो extraction करते हैं.
Ideally we shall extract, but अगर हम उसको, if the extrusion is less than 3 millimeter, हम उसे slightly reposition कर सकते हैं, लेकिन splint नहीं करेंगे ताकि वो automatically realign हो जाए. अगर realign नहीं होता then extraction is the last resort for severe cases. But अगर यही दांत परमानेंट टूथ होता तो देन व्हाट वी हैव टू डू?
Splinting.
अगर नहीं, अगर ये दांत परमानेंट होता तो फिर वी हैव टू रूल आउट कि हमारी एक्सट्रूजन कितनी है, मतलब 3 mm है, मोर देन 3 mm है, तो हम उसके मुताबिक उसको ट्रीट करते हैं, एपेक्स ओपन है कि क्लोज्ड है। आई गेस आपने एंडो के अंदर ये पढ़ लिया है, ट्रॉमेटोलॉजी।
Yes, sir.
ओके, सो अगर लेस देन 3 मिलीमीटर है तो हम स्लाइड रिपोजिशन करने की ट्राई करेंगे, बट वी विल नॉट स्प्लिंट इट, एंड आइडियली एक्सट्रैक्शन शुड बी डन फॉर एक्सट्रूसिव फ्लेक्सेशन। Follow up again like first week, 6 to 8th week, 6 months and a 1 year follow up. ये follow up बहुत important है, I'm repeating, इस पैटर्न को याद कर लें, you have to write it in every kind of traumatology. Then there is lateral luxation, then the tooth is laterally displaced in its socket. जब दांत laterally displaced हो गया, मतलब बाहर की तरफ नहीं, bodily move कर गया from labial to the palatal side. This is lateral luxation. The tooth is displaced in palatal, lingual और labial direction, मतलब अपनी जिस डायरेक्शन में था उससे bodily displace होकर labial और palatal चला गया है। Tooth is mobile, increased perial space again. अगर तो minor occlusal interference होगी तो उसकी हम slide grinding कर देंगे, अगर नहीं तो then हम उसको reposition करने की ट्राई करेंगे by local anesthesia, again splint नहीं देंगे, हम उसे reposition करने की ट्राई करेंगे in its place, but if not then extraction कर देंगे। देखिए हमने एक्सट्रैक्शन की बात करनी है, whenever it's primary teeth हमने थोड़ी सी ऑप्शन देकर without splinting, then we have to come towards the extraction side. We try to fix it with first slide grinding, and then we try to reposition the tooth with local anesthetics, and then eventually we have to extract the tooth. This was lateral luxation. Got it?
जी सर।
Okay. So this is intrusive luxation. The tooth is intruded in its socket. मतलब दांत intrude कर गया है अपनी socket के अंदर। इस तरह की जब पिक्चर देखने को मिलती है तो हम दो चीजें सस्पेक्ट करते हैं, या तो दांत फ्रैक्चर हो गया है, यहाँ से टूट गया है, तो फिर हम पेशेंट के लिप का भी एग्जामिनेशन करेंगे कि कहीं पोर्शन कट होकर लिप में तो नहीं चला गया, एंड द पोर्शन इज फ्रैक्चर्ड और नॉट, एंड देन the intrusive luxation is most dangerous kind of an injury because it's going closer towards the permanent successor. Permanent successor के करीब जा रहा होता है, तो इस तरह के इंजरीज को हमें ज़्यादा गौर से और ज़्यादा अट्रैक्शन से देखना चाहिए कि what is going to happen. But if the tooth is displaced through the labial bone plate, हमने एग्जामिन क्या करना है कि वो किस तरफ गया है, मतलब अगर हमारा क्राउन लेबली डिस्प्लेस हुआ है तो हमारी रूट विल डिस्प्लेस पैलेटली, but if the crown is displaced palatally, the root will be displaced labally. Am I right? Like this is the permanent
Yes, sir.
successor. In such cases, अगर हमारा crown palatally चला गया तो root will go labally. But if the crown goes labial, the root will go palatal side. अगर तो labial side पे चला गया तो फिर हम उसको spontaneous re-eruption के लिए छोड़ सकते हैं या उसको reposition कर सकते हैं. But if it's going towards the palatal side, then we have to extract the tooth because it can affect the permanent successor teeth. So we are supposed to extract this tooth if it's going towards parietal side, because on the parietal side there is a permanent tooth successor bud is there, so we are supposed to extract this tooth. Follow up again like it's first week, 3 to 4 weeks, 6 to 8 weeks, and 6 months. This follow up is important. I'm repeating. Remember the pattern like first week, 3, 4 weeks, 6, 8 weeks, and 6 months. Then coming toward the avulsion. Avulsion is a complete loss of the tooth from its socket. Have you ever noticed and have you ever seen such type of avulsion at your family, friends, and anywhere? कभी देखा किसी ने?
नहीं सर।
किसी ने भी नहीं देखा। क्या करना चाहिए अगर avulsion होगी है तो? बताएं शाबाश, टाइम इज लास्ट।
दोबारा लगा सकते हैं।
वेरी गुड हुजैफा, वेरी गुड, एक्सीलेंट। प्राइमरी दांत को दोबारा लगा देंगे
सर, वो अगर पोजीशन मेंटेन रखनी हो वहां पे तो लगा सकते हैं, वरना नहीं लगाएंगे।
नहीं, व्हाट डू यू थिंक कि एंटीरियर टूथ की पोजीशन इतनी
स्पेस मेंटेन करने के लिए हम लगा सकते हैं।
तो एंटीरियर में स्पेस मेंटेनर्स की इतनी जरूरत नहीं होती
सर एंटीरियर में है,
एंटीरियर में स्पेस मेंटेनेंस की इतनी जरूरत नहीं होती
उसमें
बिकॉज
एस्थेटिक कंसर्न।
एस्थेटिक कंसर्न के लिए अगर इसको तुम लगा दोगे तो जो पीडीएल्स और जो सब कुछ ऊपर से लॉस हो गया तो ये एनकालोसिस की तरफ चला जाएगा। तो इन एवल्जन द प्राइमरी टूथ रीइम्प्लांटेशन इज कंट्राइंडिकेटेड। हमने इसको कभी भी दोबारा रीइम्प्लांट नहीं करना।
ओके सर।
इफ इट वुड हैव बीन द परमानेंट टीथ देन हम देखते हैं कि इसका अपेक्स ओपन है कि क्लोज है और ट्रॉमा कितनी देर होगी है एवल्जन को। इफ इट्स लेस देन एन आवर, इफ इट्स मोर देन फॉर एन आवर, then the treatment will be subjective with it. Like अगर ये permanent होता तो फिर हम अगर apex open होता तो हम इसे reimplant कर देते because that would have been a better prognosis. उसका बेहतर prognosis होता. But अगर apex close होता and the time is more than 1 hour, then we have to go for extra oral root canal. Extra oral root canal करके इसको हम लगाते और splint कर देते. In primary teeth we don't reimplant the avulsed teeth. Remember the statement. हम उसको कभी भी reimplant नहीं करेंगे because that will lead to ankylosis. Got it?
ओके। यस सर।
It is not recommended to reimplant the avulsed primary teeth. Again, the follow-up for the extraction socket and the permanent tooth that is erupting is like 1 week, 6 months, and 1 year follow-up. अब ये हो गया जब complete loss हो गया. Now coming towards the alveolar fractures जो कि surgery में आपको ज़्यादा बेहतर पढ़ाए जा चुके होंगे या either the guys will be teaching you when a portion of the bone is fractured that is known as the alveolar fracture. In these cases then we have to splint. यहाँ पर हमें splint करने की ज़रूरत पड़ती है. Either we can rigid splint and either we can use bone plates. Ideally the surgeons know better because it's their domain. They usually do such kind of works, but since it's the part of the lecture, so I'm telling you guys a bit of it, but I am sure that the surgery people will let you know about this in more details. It's a fracture that involves the alveolar bone and may extend to the adjacent bone. यानी कोई ऐसा fracture जो कि bone में चला गया and that is communicating with the adjacent bone, and the segment mobility is there and dislocations are common. If that's in the mandible and there is a mandibular fractures, then we have to see certain things. There is displacement on opening or closure or not, like the mandible deviate करता है कि नहीं करता, and the segment mobility कितनी है, and then we have to send them to the surgeons for their work. And occlusal interference is noted. कोई ऐसा point जहाँ पर हमारी occlusal interference हो रही है कि नहीं हो रही, and reposition the segment and stabilize it with a splint for 4 weeks. हम उसको reposition करेंगे और वहाँ पर splint कर देंगे क्योंकि in primary dentition we are not supposed to go for the invasive surgeries. हम उसको splint करने की try करेंगे. We'll try to immobilize that segment or and we'll keep follow up for first week, 3 to 4 weeks, 6 to 8 weeks, and then 1 year. This can, like you can see, it's a splint. Okay, what do you see the difference? What is a rigid splint and what is a semi-rigid splint? Any guys, any of you has an idea? As the term rigid indicates that there will be no mobility in the splint. मतलब splint move करने की option नहीं देगा and that will lead to the ankylosis of the fractured part of the bone. उसके अंदर जब movement नहीं होगी तो there are chances that the clot will form and the whole process of healing will come over and the bone fracture will start healing. And what will happen in semi-rigid splint?
से थोड़ी सी मूवमेंट जो है वो अलाउ करेगा स्प्लिंट.
Yes, और उस मूवमेंट का क्या बेनिफिट होगा फॉर द टीथ?
सर वो एनकालोज नहीं होगा फिर.
Yes, एनकालोज नहीं होगा. आइडियली उसके अंदर हम जो जितने भी डेंटल ट्रॉमा होता है इसके अंदर हम सेमी रिजिड स्प्लिंट को यूज करते हैं. That will allow the micro movement so that the PDL will don't get ankylosed. हम PDL space को prevent करना चाह रहे होते हैं because the PDL is the barrier that is communicating and attaching the tooth with the bone socket. तो हमने इस PDL को प्रिजर्व करना है. अगर वो PDL खत्म हो गया तो एनकालोसिस स्टार्ट होगी. दैट विल लीड टू द रिप्लेसमेंट रिजॉर्प्शन. मतलब रूट के ऊपर हमारे पास ओडोंटोब्लास्ट या सीमेंटोब्लास्ट होते हैं एंड बोन के अंदर हमारे पास ऑस्टियोब्लास्ट होते हैं एंड देयर इज अ बैरियर दैट इज द PDL स्पेस. वंस दिस PDL स्पेस इज लॉस्ट देन द ऑस्टियोब्लास्ट जो कि बोन फॉर्मेशन करेंगे वो आहिस्ता आहिस्ता दांत की रूट को रिजॉल्व करते जाएंगे with the help of cementoclast and odontoclast, and the bone deposition will be there by the osteoblast. So that is known as replacement resorption. कुछ समझ आई?
जी सर.
Asad, please summarize the last point जो मैंने भी बताया कि replacement resorption, though this is beyond the scope of this lecture, but this is very important. अगर आपको ये concept समझ आ जाएगा कि replacement resorption कैसे होती है, तो that is good with. So please repeat this.
सर जो ओस्टियोब्लास्ट और ओस्टियोक्लास्ट की एक्टिविटी है वो काउंटर जो है वो चल रही होती है बेसिकली. तो जब कोई फ्रैक्चर वगैरह होता है तो पहले जो है वो रिमॉडलिंग के लिए जो है वो ओस्टियोक्लास्ट आते हैं. फिर
Yes.
उसके बाद जब क्लॉट फॉर्मेशन हो जाती है फिर ओस्टियोब्लास्टिक एक्टिविटी होती है और वहाँ पे जो है वो बोन जो है वो मॉडल हो जाती है उसके ऊपर.
And then eventually the tooth is no more over there. The tooth goes, and finally there is just bone.
यस
So
सर.
like you see, this is a picture of the splint जो उन्होंने fracture को reduce करने के लिए किया हुआ. This is a rigid splint ताकि हमारा जो fractured part है. Again, I'm telling you guys that the surgery people will let you know more good about this, because actually we in operative we don't have much of the fracture details to make you more clear. तो ये आप उनसे ज़्यादा बेहतर पूछ सकते हैं. That was all about your lecture. So primary dentition में दो बातें आपने याद रखनी है. कोई भी चीज जो हमें हैम्पर कर रही है हमारे परमानेंट टूथ को डैमेज करने के लिए, वी हैव टू एक्सट्रैक्ट दैट टूथ. हम उसको प्रिजर्व नहीं कर सकते हैं. So we have less than a minute now for the class. So I hope you guys understand it well. Keep studying, keep your morals high. The college is opening soon, inshallah, and then we'll be seeing you guys in class. Till then, spend your time. Have a good time.